Xin chào tất cả các bạn. Hôm nay chúng ta sẽ tìm hiểu các yếu tố nguy cơ về gen và môi trường nó tác động và gây ra ung thư thực quản và dạ dày như thế nào. Từ đó chúng ta sẽ có được những chiến lược để có thể thay đổi được những yếu tố mà có thể thay đổi và thực hiện những cái biện pháp phòng ngừa đối với những yếu tố mà chúng ta không thể thay đổi được. Bài trình bày hôm nay sẽ được thực hiện bởi bác sĩ Lisa Bosman. Cô là Assistant Professor tại Mayo Clinic. Cô chuyên nghiên cứu về mảng tiêu hóa và gan, và cô cũng tập trung nghiên cứu vào những cái mảng di truyền có liên quan đến những cái ung thư đường tiêu hóa. Ok, chúng ta cùng bắt đầu nhé.
So today I'm going to talk to you about trying to understand the genetic and environmental risks that might predispose someone to developing esophageal or gastric cancer. I don't have anything to disclose in this discussion. So the main objectives are going to be, what are the environmental exposures, which sometimes are modifiable, and what are the potential underlying genetic conditions that might lead someone to develop gastric or esophageal cancer. When I began this talk, it became very clear that there's really some major themes here. One of the themes is that most of these cancers develop through a mechanism in which people first have the normal lining, so wherever it is in the GI tract, changes. And in this situation, it changes to developing what's called metaplasia. And metaplasia is where, if in the esophagus, you should have a certain type of esophageal cell, it changes to a different type of cell. That's not a cancerous cell, it's just a cell that's in the wrong place. And by being in the wrong place, it means it's going to get exposed to something that it's not equipped to handle. And because of that, then it goes on to the next stage, which is of developing dysplasia. And dysplasia is really when we start to get into the precancerous lesion. In dysplasia, what happens is that there's some DNA damage that happens. And so dysplasia begins as low grade. So maybe the nucleus isn't quite in the same position. Maybe it's starting to change the way the shape of the cell looks. And then it becomes more progressive in moderate or advanced severe dysplasia. And then what happens is cancer can develop. And when cancer develops, then it develops the ability to become invasive or spread. So I'm going to take, for example, esophageal squamous cell cancer. So with esophageal squamous cell cancer, the defect actually happens in the basal cell. It starts to become hyperplastic. That means it becomes enlarged. And then we start to go through these stages where you get it becomes a little not like normal, then it becomes more not like normal and more like cancer, and then in fact becomes the invasive cancer. For esophageal squamous cell cancers, which are those cancers that are typically in the upper third of the esophagus, tobacco and alcohol are the big offenders, and they're worse if they're done together. And they're worst based off of kind of like dose. So the more smoking someone does and the more alcohol they drink, that increases the risk. The other thing we see is that the certain foods that contain nitrosos, like from meat, and we'll see that nitric oxide is important, a risk factor. Pickled vegetables, toxin-producing fungus, betel nuts in certain cultures are chewed, and those create a high risk for that. And even drinking like very hot drinks that scald the upper esophagus. There's some esophageal diseases that predispose. One is Tylosis, which is a very rare condition. It's a hereditary condition. And what people do is they present with really thickened skin on the palms of their hands and on the soles of their feet. And in addition to that hyperkeratosis, they have a 40 to 90% chance of actually developing squamous esophageal cancer by the age of 70. If someone's had a lye injury, like accidentally drank lye or other type of caustic injury, or if they have achalasia, and that's where the esophagus isn't really able to empty and relax well. I think it's important to realize too, so another kind of common theme that we'll see is that the microbiome matters. And the main thing I just wanted to bring up that this microbe called Fusobacterium nucleatum is seen to be in patients who have higher stage squamous cell esophageal cancer, and it's also associated with a worse prognosis. From moving kind of down the esophagus near to the stomach is esophageal adenocarcinoma. Again, it goes through this same sort of progression of developing a change. The cells start to change. Those cells aren't equipped to deal with acid. Acid is a bad thing in the esophagus. Acid's okay in the stomach. Then it starts to become dysplastic and then becomes esophageal adenocarcinoma. And this is often preceded by a Barrett's esophagus. And Barrett's esophagus is a disease we see most in white men. It's also associated with people who, as I mentioned, acid, so GERD, hiatal hernia. It's more likely, again, to occur, it's about 2 to 3 times more likely to occur in white men as opposed to, or white people as opposed to African American people. Obesity, which probably contributes through the increased abdominal pressure leading to more acid, but there's probably other things like inflammation that happens. Smoking increases the risk. Things like I mentioned before with the achalasia, again, anything that increases the acid. And then red meats and processed meats may contribute, although I think that's not 100% proven, as is alcohol is not 100% proven to increase the Barrett's esophagus risk. You can see, kind of just to illustrate, with the Barrett's esophagus, if you get the Barrett's esophagus, which is just the cells changing from the cells that should be there to more intestinal type, then there's that risk of turning to cancer is 0.5%, but it gets higher as it becomes high-grade dysplasia, low-grade dysplasia to high-grade dysplasia. Moving to the stomach, in gastric cancer, for almost all gastric cancers, we see this, again, this process. And what we see often as a precursor lesion is the intestinal metaplasia. Intestinal metaplasia can be of 2 types, and you may have heard of this. It's type 1 or type 2, and it depends on what it looks like under the microscope and whether it has what it produces. So type 1 is called complete versus type 2, which is incomplete, and the type 2 makes a different type of sialomucin. And that's often evaluated with getting multiple biopsies to look for that cause. I do want to bring up, though, that atrophic gastritis is often a predecessor for this. And atrophic gastritis, if it's autoimmune, in fact, often only happens in a certain part of the stomach. That's because chronic atrophic gastritis is related to damage to the parietal cells, and they're only in certain parts of the stomach, like the fundus in the body. And that's one where we might not necessarily see the intestinal metaplasia. But the other reasons for atrophic gastritis, H. pylori itself can cause it, which is one of the microbiome things that we'll talk about a little bit more in a minute. When we talk about gastric cancer risk, just for the stomach in general, typically it's a disease of older age, but as Jennifer just presented, it can occur in younger people, and it can occur in younger people. Sometimes we know the reason. We'll talk a bit about what genetic things might predispose, but I'd say in general, we're seeing this increase in younger onset or earlier onset of cancers throughout the GI tract. And most of the time, we're not going to know if that's caused. We don't know what the genetic cause is. Gastric cancer is more likely in men. I mentioned associated with tobacco smoking. I mentioned H. pylori, and we'll talk about that a bit more. Salty, processed foods. So in general, processed foods, as you read, they're not good for any part of your body. So, and it's also true with the stomach. Importance of family history, which we'll talk more about with genetics. People who are getting less physical activity, less fiber intake, maybe taking a lower fruit and vegetable intake, because that's not giving you as much antioxidants, and maybe that reflects also a diet that's focusing more on animal and meat, red meat in particular being a big culprit. And then if you've had prior radiation to the chest, perhaps from having had another cancer. The incidence of cardia cancer risk, which is up here, is higher in white people. It's less frequent in African Americans and Asian population. And it's not related to socioeconomic status, but in anywhere else in the stomach, it's less common in white people, but more common in minorities. And it's increased for people based on having a lower socioeconomic status. I bring up too that some of the things that we take, so for instance, if you had a risk of Barrett's, you might be put on a proton pump inhibitor. Or if you have reflux, you might be put on a proton pump inhibitor. That's trying to get the acid down in the stomach to prevent it from irritating the esophagus. Well, that's good for the esophagus, but it's not necessarily good for the stomach. And so proton pump inhibitors lead to a change in what the microbiome is in the stomach that may make a person more predisposed to developing gastric cancer. And this progression occurs sort of throughout. So what happens is the microbiome becomes less diverse. So instead of having many different species, we start to get fewer, and they sort of focus more on the ones that are more likely to be pathogenic. So the H. pylori is, as we know, related to ulcer formation, but also an increased risk of gastric cancer. Ironically, if you have H. pylori, it actually protects you from esophageal cancer, probably related to the fact that the H. pylori leads to lower acid in the stomach. So it's a tricky balancing game that's happening. And that H. pylori takes the acid down. It also likes an iron deficient state. So in fact, it often will lead to iron deficiency, which is interesting. It sort of becomes the command center for your stomach if you have an H. pylori infection. It also then leads to less diverse microbiome, and it leads to ones that you lose the ability to metabolize nitrogen properly, and that nitric oxide is really damaging to the stomach lining. So I'm going to switch now to the genetic conditions. There are autosomal, I just want to kind of go over in general what genetics are. Autosomal dominant, which is what, like that condition I mentioned, the Tylosis, is when someone inherits a mutation from just one parent, and they just have to have one copy of that gene being mutated that'll increase the risk. And so a person who carries that mutation has the potential that each of their children will have a 50% risk they're going to get that disease-causing mutation. Most known hereditary cancer syndromes are autosomal dominant, and it may be that they have other ways that we get them that aren't autosomal dominant, but those I think are the easiest ones for us to see, because you'll see a clear sort of number of family members that are infected on multiple generations. And then there's autosomal recessive. Typically with autosomal recessive, what's happened is each parent carries a mutation, and that one mutation alone isn't enough. You have to inherit it from both parents. And in that case, the chances that a child, if they had both parents having that autosomal recessive mutation, would have a 25% chance of getting that disease. This is not specific for gender, so males and females have an equal risk if it's autosomal dominant. But I think a really important thing, and that we see a lot, and particularly obvious in our CDH1 mutation patients is that with CDH1 mutations, we'll often have kindreds where the family members, I'll have a patient come in who's 35 with gastric cancer, has a CDH1 mutation. We test that person's parents. They have the dad may have the mutation but has not gotten gastric cancer. Or there may be relatives that have maybe so distant. And so that becomes really complicated for that, how to convey what that risk is for a person and for a family member to understand. And so I'm going to discuss a few other hereditary conditions that can lead to gastric cancer, and then talk a little bit more about hereditary diffuse gastric cancer. So FAP is familial adenomatous polyposis caused by mutation in this gene called APC. And people with that often get colorectal cancer, but we knew people had a higher risk of getting gastric cancer. We thought related possibly to some growth of cystic fundic glands, but what it also we're seeing is there's been this condition we didn't really know called GAPS, which was where people had gastric adenomatous polyposis. And it turns out it's actually a specific mutation, the APC gene. And those people seem to get more gastric cancer and don't necessarily manifest what we think of as FAP, which is multiple polyps in the colon, which also increase the cancer risk. Another one is Peutz-Jeghers syndrome, very rare. Those people might notice multiple sort of freckles or pigment on their lips, maybe around their eyes, on the palms and soles. They have an increased risk of multiple cancers. P10 hematomatous tumor syndrome. Also, sometimes you might hear of it as Cowden. Predisposes to some other cancers, but also does have the potential for an increased risk of gastric cancer, as does juvenile polyposis, which can be caused by two different genes. When we talk about hereditary diffuse gastric cancer, that's caused by a mutation in the CDH1 gene. That is an autosomal dominant condition. The expression that we would expect a person who has that mutation, if they're a man, to have about a 63% chance, and if they're a woman, an 83% chance of developing gastric cancer by the time they're 80. People can that risk starts to increase at about age 20. The optimal time to have your gastrectomy isn't at age 80. It's better to have done it at a younger age. I'm sure we'll hear more about how challenging it is to diagnose it. So I just want to share with you a patient I saw literally a month ago who found out her brother had stomach cancer, so she had her workup. They both have that CDH1 mutation. So she'd had an upper endoscopy. They went in and they did 80 biopsies of the stomach. They were reviewed here. Nothing showed anything other than maybe a little bit of cell atypia. And then I just heard back that she had undergone her gastrectomy, and she has stomach cancer. And so that's the danger with that condition, and why that one I think is one that we want to be very aware of. It affects young people, and it's a very difficult condition to have, and also has such implications for family members. I think it's important to think about that if you have any loved one who has cancer, because the implications can be so important for the family and for the patient themselves. So I think, you want a healthcare provider and genetic counseling team to carefully assess what your cancer risk is. See if there's maybe someone in the family's already been tested. I've had that happen quite a bit, where it turns out, my uncle had it. We didn't realize what it was. It applies to me. There's risk calculators that you can use, and it's important to choose a good test. And I just want you to be aware that the testing has really changed. It used to be we'd do one gene at a time. It was expensive. Then we would try to do the next one if the most likely culprit wasn't identified. And then that was called cascade testing. But now with next-gen sequencing, for a very reasonable price, I mean, you can get an in vitro panel done for $250 out of pocket is the max they'll make you pay. And it will test a variety of different genetic mutations. And because we're not great at always telling just based off what someone's diagnosis is, this gives us a wider perspective and allows us to find things that we weren't finding before. The multi-gene testing is cheaper. It's more likely to find a gene that's associated with cancer. It's maybe more useful, particularly in patients that don't have a particularly alarming family history. Maybe they don't have any family history of cancers. Or if they're not clear, this looks like it could be this condition, might be that condition. And the only thing I'd say as a caveat is, and I discuss this with all my patients, is your answers are going to come back either all 83 genes are normal, you don't have any mutations, or they're going to find a mutation. The most likely thing, if we find something, is going to be called a variant of unknown significance. And that to me is akin to like when you buy a desk to assemble from IKEA. You make the desk and you're so happy, it looks so good, and then you find that extra bolt. And you don't know if that bolt's going to matter. You don't know. And so with the variant of unknown significance, that means we don't know, and time will tell. The benefit is that you will be contacted if that variant of unsignificance does become what we call pathogenic, meaning it could cause disease. And we don't recommend it if you know your family member has a CDH1 mutation, or if you so clearly have a condition, for instance, called Lynch syndrome, which I didn't mention, but which also can cause risk for gastric cancer. And then just to say, as we saw, younger people can get this condition. So I think it's important to be aware for the patient who may still want to be having children in the future. We know that the chemotherapy could have impact fertility, and there's lots of approaches for this. You can, for men, cryopreservation of the sperm. For women, embryo cryopreservation, even using oocytes that are unfertilized. For instance, if the person doesn't have a partner with whom they want to have a child at this point. Sometimes even because, as we've seen, I think from the case that Jennifer talked about with the family where people are getting this even in their teens, is that perhaps a young woman hasn't even gone through where she'd have oocytes that would be viable. So sometimes they can even do ovarian tissue cryopreservation. And then if you're taking certain types of chemo, they can give you medicines to protect the ovaries from failure. And I just want to stress again, the impact is so important for the familial cancer risk, because it might help a family member get diagnosed and get into the proper screening. It might lead to prophylactic interventions, say, for instance, with the CDH1 mutation, getting a gastrectomy before cancer develops, or being in a better breast cancer screening. It can lead to predictive genetic testing for those other family members. It might help guide chemo prevention or even chemo or surgical options. And then pre-implantation genetics, which is where if you know what a mutation is that you harbor, you can actually select to have an in vitro fertilization to implant an embryo that you know is not going to carry that mutation on. And I've had that, many patients have that done, and it's really been a big source of relief for them to know that their child won't have to go through what they went through. So just in summary, environmental and genetic risk factors, the majority of modifiable risk factors really are pretty much the same throughout the upper GI tract. Gender, meaning at the chromosomal level, is not modifiable. Race is not modifiable. Age is not modifiable. There are some socioeconomic differences. As I talked about, really gastric cancer is the one in which we know the most about the genetics, but for esophageal squamous cell and adenocarcinoma, it's very likely we see familial aggregates, but those genetics haven't yet been identified. So thank you for joining us and listening to that discussion.
Vâng, bài học đến đây đã kết thúc. Cảm ơn các bạn đã chú ý lắng nghe. Các bạn nhớ like, share and subscribe để theo dõi các bài học tiếp theo. Xin chào và hẹn gặp lại.